A very good evening to everyone. Welcome everyone, all the KSCASI members. For that, request our chairman, Dr. Narayan Chandra Hebsur, to do the welcome address.
Good evening, everyone. It's a great pleasure to have today's ward rounds from our professor and HOD, Dr. Gurushantappa, who is a national EC member also. And with him, the presenters are Vijay Reddy, Kruti Venkatesh, and Kruti Pendyala. Wish you all the best. Everybody, all of you very well. It's a great session. I welcome all the legends of surgery, Dr. Shivram, Dr. Lakshman, and many more people are there. Even Dr. Jogendar sir is there from Imphal. Welcome. And we can start the program. Chandru, please continue.
Yes, sir. This webinar is moderated by, as chairman told, Dr. Gurushantappa Yalagachin, sir. He is working as professor and HOD, Department of General Surgery, KMC Hubli, and is also the national EC member of ASI. Without wasting much time, I request Gurushantappa, sir, to start the program.
Please mute everybody.
Good evening, everyone. So at the outset, I thank our chairman, Karnataka State ESI, Dr. Hebsur, Secretary, Dr. Chandrashekar, and all the EC members of KSCASI for having given this opportunity of having ward rounds with my postgraduates. Dr. Vijay from BMC Bangalore, Dr. Kruti from Hubli, and Dr. Kruti from KMC Manipal. This is a case where I'm going to give a scenario in the beginning, and we will have a little bit of discussion at history level and examination findings level. And I'll be giving the details of investigation and the treatment, followed by a little bit details of the case which we have treated in the wards. This is a gentleman with 34 years old, known alcoholic and a tobacco chewer, presented with history of pain, abdomen, and breathlessness of 8 days duration. He had history of back pain, and he was treated before he came to us, that is on 8th day. He was treated in some other hospital for the same complaints. He had history of vomiting, history of fever, and before the onset of pain, he had a bout of alcohol consumption. There were no earlier attacks, and he says he is more breathless in lying down, and there is no history of cough. He is not a diabetic or a hypertensive. This is a short history. Just I wanted to know what are your thoughts with this short history. Vijay?
Sir, it may be acute pancreatitis, acute severe pancreatitis, because he's having breathlessness. It's a known case of alcoholic.
Okay. Kruti from Hubli, any idea other than this? Straight away pancreatitis or any other you want to keep in the mind?
No, sir. All the symptoms and history is pointing towards pancreatitis. He's a young male. He's a chronic alcoholic. He's had a binge before this onset of pain, and he says typical pain of epigastric pain with a history of back pain, and he's having symptoms of fever also with breathlessness, pointing towards acute pancreatitis, sir. But I would like to
from Manipal, anything you want to differ with their thinking or same?
Same, sir, but
okay.
It can also be a case of a perforation also to be considered, sir, because chronic alcoholic, so peptic ulcer, perforation.
Exactly. Since he is a tobacco chewer, just because the alcoholism is there, yeah, thinking in terms of pancreatitis is right. But at the same time, you cannot take away the other causes for acute abdomen, the most commonest being acute perforative peritonitis, maybe secondary to hollow viscous, that is duodenal, because he's a tobacco chewer also. But I say it is a cardiac cause because the patient says the breathlessness is more in the lying down position. Any points against? I say because of that particular symptomatology, I say it is a cardiac cause.
So, but cough is not there, sir. So usually
Not
they
necessarily. In cardiac, cough will not be there. Typically, they will have the orthopnea. So that is a point I'm taking, and I put this as a cardiac cause. So can you rule out this straightway at this point of time with this history?
So the patient has pain, abdomen, and breathlessness since 8 days of duration, sir. Such a long duration, it is unlikely to be a cardiac event.
8 days duration. 8 days is not a long duration. Anyway, your thinking may be right, keeping the pancreatitis and perforative peritonitis as first two possibilities. But what I expected from you people as a postgraduate with an unbiased thinking at history level, young fellow, 34 years, earlier absolutely fine. If it is a cardiac cause, what the pathology or what disease we expect at this age? Maybe rheumatic heart disease, maybe some congenital problem. So he would have had the history, long history of breathlessness to start with. It is not just 8 days suddenly starting at this age. Okay, so yeah, and predominantly you would have had a breathlessness than pain abdomen if it is a cardiac issue. Pain abdomen in cardiac issue is hepatomegaly, tender hepatomegaly can cause pain abdomen. Third history which is lacking in this, a history of pedal edema, like giddiness or getting tired while walking, all those histories just
on exertion.
Yeah, exertion. Unbiased, just keeping in a broader way that yes, these are the possibility at this only with this short history. Okay, so just to keep it in mind. So with those points, you have ruled out or unlikely that probably it is not a cardiac cause. So we'll keep those two possibilities priority. One is the pancreatitis. And Vijay, straightway you cannot put it as like a severe form at this point. I take it your point of breathlessness with pancreatitis, yes, it becomes severe pancreatitis. But at this point of time, if you're thinking in terms of a pancreatitis, probably it is a case of acute pancreatitis. So that way you can put it. So you would like to know the examination findings?
yes.
Okay, these are the general physical examination findings. He was looking tachypneic, otherwise conscious. There was no pallor edema, and he was febrile, little on the higher side. Hemodynamically stable. There was tachycardia, and SpO2 is 78% at true male. Means when he came to hospital, he needed oxygen inhalation to maintain saturation. Okay, so anything you want to give information at this point, Vijay?
Is in
Kruti,
the
Hubli?
patient.
Yes, sir. Systemic involvement is to be taken into consideration here, sir. Patient is tachypneic, that means respiratory system is involved. His pulse rate is on the higher end. That means he's already in the inflammatory phase, sir. And he's not able to maintain with that.
I'm going a little fast because we need to proceed.
Yes, sir.
Yeah, Manipal, Kruti.
Yes, sir. So patient, it appears that patient has almost 3 of systemic inflammatory response syndrome, sir. So patient is tachypneic, febrile.
Okay, what I want, again, even though you know the case, what I want is unbiased thinking at this point. Any general physical examination findings suggest that whatever the local disease he has, already there are systemic evidence of this sepsis, if it is a sepsis. Means it is not a localized disease in the abdomen. It is going into the chest also, probably involving the respiratory system. What are the points in favor of involvement of the respiratory system? History-wise breathlessness,
saturation.
patient is febrile, saturation is not good, okay,
not maintaining
and
a
patient is tachypneic. So along with the local disease, likely that there is a one system involvement, that is respiratory system at this point of time. Is it right?
Yes, sir.
Okay, these are the local examination findings in the abdomen. So there was a fullness, not like a definite mass in the epigastrium, occupying right and left hypochondrium region, and tenderness. There was guarding, and liver dullness was not obliterated. There was no evidence of free fluid. Otherwise, remaining examination was normal, and there is a decreased air entry on the right side with a dull node. So what is your thinking with this?
Right pleural effusion.
Very good. Okay.
Here, liver dullness is not Obliterated, sir. So our previous
Okay.
thinking where perforation, when we were considering, in that case, the liver dullness will be obliterated.
Name
So-
one condition where there is a perforation of hollow viscous, but liver dullness is not obliterated, just for information.
A sealed of
Massive.
Okay, okay.
Appendicular
Maybe, yes,
perforation.
exactly. Appendicular perforations. So the first diagnosis where there are peritonitis signs, but there is no obliteration, even radiologically, there is no obliteration of the liver dullness, keep a possibility of appendicular perforation. Okay, so with this finding, what is likely thinking?
Acute excessive pancreatitis.
Yeah, maybe pancreatitis because that fullness guarding in the upper abdomen with no obliterated liver dullness and right side decreased air entry. Likely that it could be a case of pancreatitis. These are the blood investigation finding in this person. Okay, just I'll sum up. Total count is high. Otherwise, the amylase and lipase are on a higher side, very high. And the calcium is 7.6, lower limit of the normal. And the chest X-ray showing the massive pleural effusion on the right side. And the CRP was not done because of the constraints in the institute. So this is what it is. So what is your inference with this slide?
Sir, usually hematocrit is the only thing which will decide the severity of the pancreatitis, sir. Because of dehydration, hematocrit will be raised.
Okay. Vijay, I want a discussion unbiased. Like, don't keep pancreatitis in the head and try to correlate these findings. I don't want that. What I want is these investigations should be explained. So ultimately, what is that you want to say? That he raised PCV, probably there is an inflammatory process going on in the abdomen. Total count is high, probably there is a severe sepsis going on in the abdomen. Okay. Now adding amylase and lipase levels to that sepsis, those findings, probably it is pancreatitis. That is a cause for those raised total count and PCV. So we will correlate like that, rather than coming back and keeping pancreatitis first and trying to explain the findings. Okay. So otherwise the remaining parameters looks normal. Okay. In this fellow, LFT is almost normal. What is that? It is ruled out.
So a biliary pancreatitis. Gallstone pancreatitis.
Biliary pancreatitis. Okay, it may not rule out. What I wanted is, since the person is alcoholic, so it is very less likely that probably he may not be having the alcoholic liver disease. So it is a pancreatic disease alone, because many times alcoholic pancreatitis may have associated alcoholic liver disease. So with these parameters, likely that liver is functioning still normally. Okay. Any idea about the serum? One you said, which I said, PCV. Yes, it indicates the severity of the pancreatitis. Hubli, Kruti, what is the calcium? Anything you would like to add? Level of serum calcium? Yeah.
Serum calcium less than 8 mg, that signifies that the patient is having ongoing sepsis where the calcium is getting deposited somewhere. It's getting consumed. So it is definitely on the lower side. So I'm suspecting that there's an ongoing inflammation.
It doesn't signify inflammation. It doesn't say that somewhere it is getting deposited. You should be very specific when you talk about pancreatitis with calcium. It is the consumed calcium going for saponification of the omental fat and the peritoneal fat. Hence, serum calcium comes down. This is the X-ray of that particular patient. Can you read the X-ray? It is very obvious. Manipal?
Sir, there's on right side, there's obliteration of the costophrenic angle, and so it appears like a massive right side pleural.
Exactly. Almost hemithorax is hazy. Right hemithorax. Okay. And left hemithorax appears normal with a normal CP angle. Obviously, it is a right-sided massive pleural effusion. That is the ultrasound image, what I have put on the right side, that is showing at the pancreas level cuts. So obvious it was a pancreatic necrosis. Okay. So what is that you would like to get from this now, after this? What is that you would like to have, Vijay?
So next we should get CECT abdomen, sir, to look for any.
How do you justify getting a CECT in this person?
To look for any collection.
Okay. Why
And the thing is,
CT?
first
Why
you should
CT?
get-
Why not treat the patient with this? Okay, Kruti, Hubli.
Yes, sir, definitely, sir. After USG abdomen, which is suggestive of pancreatic necrosis, there has already been history of 8 days of pain. So by now, the necrotic the pancreas undergoing necrosis would have shown some signs. So I would want to look for the extent of necrosis, any peripancreatic collection, and the collection in the abdomen, peritoneal cavity.
Okay. So this person fits into that more than 72 hours becomes an indication for getting a CECT. And you would like to know the details, other details, so that you can grade or you can put into what severity of pancreatitis. Without having the imaging in the form of CECT, you cannot grade the severity of pancreatitis only with a sonography. And without grading the severity, you cannot treat pancreatitis. Okay. Plus associated other problems.
Sure.
Okay, definitely for that CECT is a must. This is the CECT report. Kruti from Manipal, can you read this?
Yes, sir. There is a peripancreatic inflammation of fat strangles and areas of necrosis is also seen, sir.
Okay. Yeah, whenever you have been asked to read a CECT of pancreatic diseases,
yes,
go from the pancreas away. Go
Okay,
from the. These are the cuts taken at pancreatic level. Okay.
Yes, sir.
So you can see there is no vascularity here. That is suggestive of. That is hypoechoic area. That is suggestive of necrosis. And there is fluids on either side. And this is a peripancreatic area where there is fat stranding. In the sense, this is pancreatic necrosis. There is peripancreatic fat stranding also and fluid collection around. So it fits into what? Now, finally, with this CT report,
acute severe pancreatitis.
acute severe pancreatitis.
Pancreatitis.
What is the clinical triad of pancreatitis?
Sir, abdominal pain, raised amylase or lipase levels, and
Imaging findings.
aging showing.
Imaging finding. Raised levels 3 times the normal.
3 times.
Typical pancreatic pain. You have to use the same words like typical pancreatic pain, raised amylase level and lipase more than 3 times the normal, and typical imaging findings. That fits into diagnosis of acute severe pancreatitis. Okay, what is to be done now for this?
So first initial fluid resuscitation, and then analgesic also, sir, like adequate analgesia, and also patient will require ICU admission, sir, in this case, because he's not maintaining saturation without oxygen support. So that is a criteria for ICU admission.
So this person obviously needs to be treated in ICU, okay, because of severe pancreatitis with a respiratory system involvement. Definitely he needs to be treated in ICU setup. For your information, these are the indications for the fluid case of pancreatitis to be treated in ICU, where BMI is more. Patient is a known diabetic with acute pancreatitis. Patient having oliguria, tachycardia, a presence of encephalopathy. Then the narcotic agents will not help him to control the pain. Having pleural effusion and hypoxemia, and hypotension refractory to fluids and other ionotropes. Definitely need to be treated in ICU. So this is just for your information. All of you must be knowing about CT severity index. That is a Balthazar score, depending on. Just remember, first normal pancreas, then comes only enlarged pancreas, then inflammatory around the pancreas with single or multiple collections. And with a contrast, when it is being done, yes, definitely we have to classify the necrosis into 3 parts, less than 30, 30, 50, and more than 50%. And accordingly, it is being graded, mild, moderate, and severe. What is this? Any idea? Modified CT severity index?
Modified CT severity index includes, other than these points, extra pancreatic complications as well, sir, which is seen in systemic involvement.
Okay, what is our indexed patient with this? What is the score it fits into? Okay. If you are taking only the CT severity index, yes, it is because maximum score is 10. We're including the pleural effusion where 2 points are given. So our patient fits into 10 or 12. So ultimately it is a diagnosis of severe form of acute pancreatitis. So any idea about these scoring systems for grading of severity of acute pancreatitis? Manipal, Kruti?
Yes, sir. The bicep score, it's a bedside scoring system, sir, where we use the blood urea nitrogen, altered mental status, then the age more than 60, then we have the pleural effusion, and also we include the is
Source.
Yeah, any idea about transients, Kruti?
Yes, sir.
Yeah.
Ranson's is different in gallstone pancreatitis and non-gallstone pancreatitis. So we grade it based on 5 criteria at the time of admissions, and after 48 hours, we look into other 6.
It is just for, yeah, fine. It is for the information. This is for our all postgraduates information. This is what it is, what she said, Bishop. And a commonly used from many institutes is the Bishop scoring system. Very simple. The parameters are available in every setup. And a simple pleural effusion in a chest X-ray, yeah, definitely we can classify patients into the mild or the severe form. This is at admission and at 48 hours. I will not go into all the details. So these are the different the systems for Apache also is one of them. Commonly used is modified CT severity index and Bishop scoring system. With these two, definitely, and CRP levels can be classified into whether it is a mild, moderate, or severe form of acute pancreatitis. So as a postgraduate, you should be knowing about what is Bishop, what is CT severity modified, and then CRP and other inflammatory markers, that is procalcitonin also. So I will not go detail of all them. So please remember, these are the inflammatory markers, these are the image findings, these are the grading systems. So if we can classify and remember, that is more than enough. So in the indexed patient, this is what was done by putting an ICD because it was a massive and he was not maintaining respiration. Otherwise, what would have done? Because saturation was not good and he was breathless, so hence ICD was put. Otherwise, if the patient was not much breathless, minimal pleural effusion, and maintaining saturation, what would have been the procedure would have done for pleural collection?
Aspirations.
Needle. Yeah, pleural
needle aspiration.
Needle aspiration would have been enough. Okay. Here ICD was put because of the reasons mentioned. What are the other ways of treating? Any other adjuvants who you would like to give in this, Vijay?
Yes, sir. If there is any pancreatic collection, usually get an aspiration to be done, sir.
Okay. Before that, you should mention fluid resuscitation and antibiotics. Yes. Okay, because it is there are inflammatory markers are raised. There is evidence of sepsis and a severe form of pancreatitis. Why I mentioned ICD first? Because that has to be tackled first. Then the fluid resuscitation and antibiotics. What is antibiotic of choice in acute pancreatitis?
Meropenem.
Meropenem. Even quinolones are given with coverage of anaerobes, that is metronidazole. Okay. Do you want to give oral feeds or a TPN, or you want to give only IV fluids in this fellow? Kruti, Hubli?
Oral.
Sir, patient does not have episodes of vomiting anymore, sir. So we can start oral fluid, sir. At least oral non-fatty diets.
Okay, Manipal, anything you would like to accept her because he doesn't have vomiting, she wants to give oral feeds. Is that the reason or any other reasons for early enteral feeding in pancreatitis?
Sir, it maintains the gut mucosal integrity, sir. So the translocation of the bacteria will be
lessened. There is a proved literature mentioning that early enteral feeding lessen the necrosis getting infected. Okay, so that is a one reason. Yeah, he not having vomiting, give oral, yes, accepted. That is logical. But there are benefits of doing an early enteral feeding. So we should, so that everything is thrown down and the necrosis which is there sterile, less likely that it will get infected, which is a very important marker for prognosis of acute pancreatitis. TPN, not much role, not much role. For a pancreatitis per se, TPN doesn't have much role. In fact, part of the TPN may induce pancreatitis. Okay, so not a, just I put as a question, not a rule. What about the other two drugs which I mentioned?
Not much role, sir.
Not much role,
Okay.
sir. Octreotide
If
and
at all, if
simvastatin.
somebody is using, what is their way of like, how do they act?
The exocrine secretions of the pancreas are reduced, sir. It's not
Suppressed by these drugs. Okay, so hoping that you are not making the pancreas to work more when it is diseased. So with that thinking, these drugs were started to give a rest to the pancreas because it is already inflamed. So give rest by suppressing those secretions. That was the thought. But they have been proved already that yes, these two drugs doesn't have much role in the treatment of acute pancreatitis. Okay, any role for USG-guided procedures in this, Vijay?
Yes, sir. If there is any pancreatic collection, is there?
Okay. Okay. This is the follow-up of this patient. And yeah, you can see in the X-ray that there is a good resolution of pleural collection. And these are the blood parameters. Anything, Manipal, Kruti, anything obvious in these blood reports compared to the previous one? I will not read out everything. Anything obvious?
Yes, sir. The total counts are still rising. The serum calcium also has reduced further, and the patient is still febrile. And the urine output also is 800. It's patient is oliguric also, sir.
Okay. PCV has gone up compared to previous one.
Yes.
Temperature has gone up. With this, what do you expect with the CRP? Even though it is not done with the previous report and this, what do you expect in CRP?
Increase it will
Increase. So looking at all these blood reports, what is your next thought to this patient?
that the patient is deteriorating, sir, in spite of the conservative management.
Okay. So what is your thought now? What is your next? Yeah, Hubli, Kruti, what is your next with this? She said, patient
sir,
is not responding to our treatment. He's getting deteriorated. So what is next?
Sir, yes, sir. It has been almost 48 hours since the last CT. Now I would want to get a repeat CT to see further progression at the local sites.
Okay, this is the repeat CT.
Yes, sir. There is increase in the amount of non-enhancement in the pancreas. So increase in necrosis is there. There is increased peripancreatic fat standing. And also we can see that the bowel wall edema is there. So it's
Exactly.
definitely.
Please remember the third image. There is even a generalized fluid, peritoneal fluid. That is why there is a bowel wall edema, which was not there earlier, even though I have not shown the cuts in the previous. So this pancreatic necrosis almost occupying whole of the pancreas. It is more than 50%. The amount of fluid around also has increased. So it is getting worsened. It is getting worsened. So now there is collection around. Then it becomes an indication for, what is this left photograph, Vijay?
Sir, USG guided as pigtail insertion, sir.
Exactly.
For pancreatic collection.
Okay, okay. Is it the right place? What has been placed in this patient?
No, sir, actually.
No,
But
because is it the? Huh?
It's not the right place.
Lateral.
Exactly. So where should have been? We should have been in the lateral side.
Lateral side.
Yeah, probably why the treating clinician did was when the ultrasound was done, probably, yeah, access was, it is nearer to the surface of the abdominal wall, hence it was. Otherwise, it has to be in the lateral side.
Lateral side.
So this is the pigtail drainage. So this is the one we started doing on third day, that is after admission. And these are the blood parameters, the next parameters. Anything you want to opine, Kruti, Hubli?
Yes, sir. Total count is still high. PCV is again showing higher trends. Sir. More hemoconcentration is there. Temperature is still high. And yes, sir. Calcium.
So ultimately, what is the message conveyed with this?
Sir, the ongoing inflammation is still continuing, sir.
In spite of putting a pigtail catheter, and it has drained around 700 ml in 24 hours. Fourth day it came down. Is it not?
Yes.
So it has worked. It has worked. This drain pigtail catheter also has worked. ICD also has worked. but
But
his
patient-
parameters are not coming down. Yes, yeah, exactly. So again, that becomes an indication for
CT.
further CT evaluation.
CT.
Why further CT in a pancreatic pathology is that is the only imaging which will tell us that what exactly is going on in and around the pancreas. Otherwise, no other investigation will guide us. Hence, CECT becomes the important tool for evaluation and taking calls for further treatment in acute pancreatitis.
Pancreatic.
Okay, so this is what it is. What is obvious in this CT cut? This is the
Air
third
Air
CT now.
pockets. Air pockets were present.
Exactly. Is it a good sign or a bad sign?
No, sorry, it's emphysematous pancreatitis.
You want to put it as emphysematous pancreatitis. Any other way? Already it is a proved case.
Infected
It's a proved
necrosis.
case of pancreatitis. Now which was not there earlier. Now you are seeing these air bubbles in the pancreatic area.
Infected necrosis.
Exactly, infected with NROs. Infected necrosis. So infection is getting progressed. Not a very good sign. Having air bubbles in and around the pancreas in a proved case of pancreatitis is not a good sign. Sepsis is becoming still more severe. And these are the parameters again. These are the parameters. Okay. What is the role of knowing increased creatinine in the sepsis?
That means even the renal system, renal functions are deteriorating. So that means there is increase in hemoconcentration, vasoconstriction. There is hemoconcentration leading to less oxygenation at the level of glomeruli, deposition of inflammatory products in
So
the
it is a sepsis-induced renal shutdown. Patient is going for sepsis-induced renal shutdown. Okay, and PCV also is getting increased in this level. Does this amylase and lipase have got any role here? Levels of amylase and lipase in our taking decisions?
No, sir. Even though
No,
the
sir.
amylase and lipase levels have come down, the disease is still progressed. So it is not indicating the level of severity.
The sense, the levels of lipase and amylase, they are nothing to do with the prognosis and the severity of pancreatitis.
Pancreatitis.
Okay, fine. So what is to be done now?
So the step
Things are
up
going
approach.
further.
Step up.
Yeah, what is that? Ajay,
So-
Vijay.
Endoscopic. Sir, endoscopic approach.
Okay. What is that you would like to do with endoscope?
Sir,
Yeah, Kruti, Manipal. Yeah.
endoscopic transgastric drainage
Of-
we can
Okay.
sir,
Kruti.
or also we can like lamps like lumen opposing metallic stent can be placed by
Very good.
to drain
Okay.
the collection.
Okay. What is required if your plan is to do endoscopic procedure? What is must before you plan your endoscopic procedures? You need to have a EUS. Okay. So all the endoscopic procedures on pancreas should be done with the guidance of EUS. So without EUS, just with the endoscope, difficult to approach because you need to have some guidance so that you'll be able to approach exactly with a needle, then dilator, then putting stents. Okay. And that is the best way of doing endoscopic. That is called endoscopic necrosectomy or putting a stent, luminal opposing stents, so that you'll be draining everything into the stomach. Any other procedures?
Sir, VADS, video assisted retroperitoneal debridement, sir.
Very good. Next.
Sir, we
Or
can combine endoscopic with percutaneous drainage.
Percutaneous.
Okay, percutaneous drainage. Yeah.
Sir, in spite of
laparoscopic necrosectomy.
Okay. All you should have started with the minimum possible and then to the maximum. Okay. And these treatment modalities depends on, is it only the fluid collection or is it associated with the necrotic collection also? If it is a only fluid collection, the first preferred method of doing it is a percutaneous ultrasound guided aspiration. Because it is fluid, you'll be able to aspirate. If there is a solid component in the form of necrosis along with the fluid, infected fluid, then it is very difficult to manage only with a percutaneous aspiration. Then what all the procedures you people have mentioned till now, everything fits in. I will not go into the details of everything. These are all what all of you have mentioned. Exactly. All can be tried. And it has to be started with the minimum possible procedure to the maximum invasive procedure. That is what is called step-up approach in the treatment of acute necrotizing pancreatitis. Step-up approach that is typically described. In this particular patient, since other procedures are not being done in our institute, it was straightway open necrosectomy was done for this patient, and later he definitely he improved, and patient we could discharge the patient almost after 3 weeks. Okay, this is what it is. So please remember these different procedures, that is step-up approach, starting with endoscopic procedures. Okay, so for your information, these are all the indications for surgical or intervention in the treatment of acute severe pancreatitis. These are the guidelines. For example, if it is a gallstone pancreatitis, patient will land up with cholecystectomy after managing acute phase. Then if there is a disruption, either we should put a stent or a distal pancreatectomy or a Whipple, depending on the site of the transection or the disruption of the. Then pseudocyst may require intervention because most of them may respond spontaneously. And if it is an infected necrosis, yes, initially aspiration with a pigtail and other procedures followed by necrosectomy. Then if it is an abscess, if it is formed an abscess, external drainage is a must with antibiotics. Okay, if there is no response, this. What the Kruti from Manipal was mentioning, yes, the LAMS, that was what I have shown in the picture. Lumen opposing stents between the cyst and the stomach wall. So these are the audit standards in case of pancreatitis. Whenever we have pancreatitis proved case, our mortality should be less than 10% overall, and in severe form in the literature it is up to 30%. And you have to have a correct diagnosis, including the etiology, within 48 hours of admission. So the etiology, at least only 20% of the diagnosed cases of pancreatitis should be labeled as idiopathic. In the sense, when you get a case of acute pancreatitis, we need to find out what is the cause for pancreatitis in that particular patient. Okay, in 80% of the people, if we put our efforts with all the modalities available, see that you find out the cause. Then severity should be classified within 48 hours. Otherwise, treatment becomes difficult because there are set protocols depending on the severity. So you need to classify that given patient within 48 hours. And all patients with a biliary pancreatitis needs to have a definitive treatment, that is laparoscopic cholecystectomy in the same admission. So one of the literature that is Panther trial mentioning or supporting a step-up approach in acute pancreatitis. Kruti, Manipal, anything you would like to mention regarding the levels of amylase, lipase, and the pancreatitis?
Sir, amylase it starts increasing within few hours, and it usually presents up to it's present up to 4 to 7 days, sir, and then it starts decreasing. Whereas lipase, after onset of symptoms, about 72 hours later, it starts increasing in the serum levels, and then stays up to 2 weeks, sir.
Okay, so if the patient has presented to you at a later date, 8 to 10 days, probably the diagnostic modality will be lipase levels. Okay, but ultimately in the literature, what is mentioned more specific is lipase than amylase levels for the diagnosis of pancreatitis. But whatever the levels you have, acute the amylase and the lipase, they doesn't predict the severity of pancreatitis. In fact, in some cases of alcoholic pancreatitis, amylase levels may be low or normal in spite of having a pancreatitis, because there is no parenchyma to secrete amylase or lipase in spite of having a disease there. So there is only diagnostic in an earlier case, and they don't predict the severity of pancreatitis. Like you people have mentioned the role of octreotide and somatostatin. This is one article mentioning, yes, they don't have a much role. One more pointer trial indicating that, yes, it is a step-up approach which is more important in the management of acute pancreatitis. These are a few clinical practice update I have just mentioned here for the information to all the postgraduates. There are 15 advice practice guidelines for pancreatitis. Just a few of them I have mentioned here. It has to be a multidisciplinary treatment. And prophylactic antibiotic, they don't have any role in the treatment of acute pancreatitis unless there is. There is some background sound. Yeah, thank you.
Sorry, the rain got delayed. Oh yeah, little workout done. I'll get the other part.
Can you mute? Somebody is speaking. Can you mute, please?
Done, sir. Done, sir.
Prophylactic antibiotics, they don't have any role when there is acute or mild or moderate pancreatitis without any evidence of sepsis. Okay, so antibiotics are recommended, like you people have mentioned, once you have proved that the necrosis is infected one, or it is going to be infected, or there are inflammatory markers which have been raised. The drugs which are commonly used are like carbapenem, quinolones, and metronidazole. Like we mentioned in the beginning, early enteral feeding. Even if the patient has got vomiting or not tolerating, you can have a feeding tubes inside into the stomach, duodenum, or into the jejunum, scopy guided tube insertion, and then patient can be fed through the tube. Okay, so that will hasten the recovery of acute pancreatitis. If there are collections within 2 weeks, better not to intervene in the form of draining those collections. You can wait and plan for the drainage of those collections if they are not responding after 2 weeks. The preferred method of drainage, if it is only the liquid format, then percutaneous aspiration. If it is a necrotic and a fluid, probably the other means we should be trying. Commonly used is endoscopic drainage procedures. And definitely step-up approach from minimum to maximum is the preferred way of treating these pancreatitis patients. When there is a disconnection, okay, Vijay, if there is a disconnection of pancreatic duct and there is a collection around resulting in pseudocyst, what is that called? If there is a duct disruption with a collection resulting in pseudocyst formation, what is that called? It's a communicating cyst, duct communicating cyst. So this is another 3-4 slides I have put for the postgraduate stage. So when it is asked, what are the types? These are the 2 types, last one, edematous pancreatitis and a necrotizing pancreatitis. Again, each one of them, depending on the duration, they are classified into 2 types. If it is less than 4 weeks, anything around and in or under pancreas, in interstitial pancreatitis, it is called acute pancreatic collections. If it is more than 4 weeks, then only we label that as pseudocyst. The other form is necrotizing pancreatitis. With that, if there is a collection and the duration is less than 4 weeks, they are called acute necrotic collections. If it is a more than 4 weeks with a necrosis, then it is called walled-off necrosis. Then what are the 2 phases of acute pancreatitis? Early phase within first week, late phase after first week. How they are classified the severity? Mild, moderate, and severe. Mild, there is no organ failure, only there is inflammation, swollen pancreas. Moderate, there is a transient organ failure in the form of kidney, respiratory system, or hemodynamic status. Within 48 hours, and again the patient settles. That fits into moderate. Severe form, persistent organ failure, where beyond 48 hours, all 3 organs can be involved, including the mental status. So to make it simple, so that there is no confusion with this. All the pancreatitis, among them, most of them are mild variety, fortunately. 90%, 90 to 95% are mild variety. So mortality is very less. So only 5 to 10% fits into severe necrotizing pancreatitis. Out of them, again, fortunately, 60% of them will have a sterile necrosis. Only 40% will have an infected necrosis. This last group, that 40% group, carries the highest mortality in pancreatitis. This mortality, more than 50% of the mortality happens in first week or first 10 days of acute pancreatitis. That is because of extensive inflammatory response in acute pancreatitis. That is the one which is going to kill the patient. So extensive, massive inflammatory response with all CIRS syndrome, That is the one in first 10 days. That is a cause wherein it will cause fluid loss throughout the body, fluid collection, respiratory system involvement, renal shutdown. If the person crosses this and if it goes beyond 10 days or 2 weeks, then the sepsis sets in. So later death in acute pancreatitis, these questions may be asked. The later death in acute pancreatitis is because of sepsis. Earlier mortality in acute pancreatitis is because of severe or massive inflammatory response. Again, what I have mentioned, the same thing I have mentioned here. So depending on the collections, yes, it is what is the acute peripancreatic collections, pseudocyst, walled up necrosis, and a necrotic collections. This we have mentioned in the beginning. This was the original 1992 Atlanta classification where they used many terms and there was a lot of confusion because they wanted to include all the grading systems in the same system. So it got a little confused and then it was modified in 2012 and they have made it very simple. Again, if it is a less than 4 weeks, it is interstitial edematous pancreatitis. Again, it is sterile or infected. If it is more than, then necrotizing pancreatitis. Okay, so this is what you should remember. Less than 4, these two types. More than 4 weeks, these two types. Okay, so more than 4 weeks, here comes the pseudocyst and walled off necrosis. So here acute necrotic collections, acute peripancreatic fluid collections. This is the Atlanta classification. For your information, just these are the two important inflammatory markers with these parameters. What is Sir's syndrome and what is Hughes-Sofa syndrome. So these are the components which are taken into consideration. This is a graph which is showing the mild and severe form of pancreatitis in first 10 days and beyond 10 days. Okay, so this one, first initial phase of this, initially it will be a first systemic inflammatory response syndrome. Then between 10 to 15 days, the next wherein there is a local complications in the form of peripancreatic, the fluid and organs are not completely failed, they are transiently failed at this point. That is a mixed antagonist response syndrome, where there is little bit aggressive inflammatory process, but again at the same time there is a transient organ failure. When the disease process continues, then there is a compensatory response syndrome wherein the organs start failing and this becomes a permanent organ damage. Okay, so again, indicating that what is the importance of knowing these inflammatory markers in acute pancreatitis. So again, this is one of the slides showing the different forms of severity and their involvement. So with this, I once again thank KSCASI and I have for the opportunity given. This I have made it very simple for the postgraduate level. There are many things which needs to be discussed in acute pancreatitis. My only suggestion for the postgraduates, don't get confused with acute and chronic pancreatitis. There are two different disease processes or benign diseases, common benign diseases involving pancreas, having their own etiological reasons, different pathology, different treatment modality, and different outcomes. Okay, don't get confused. Even in the examination, if you get theory question also, don't mix up the issues. There are two different entities entirely. So please understand what exactly, and you will be learning about the inflammatory markers in acute pancreatitis, and the treatment modality is different. Okay, so I hope I have made it clear for the postgraduates. So if anything from my other colleagues, I'll be very happy to know any shortcomings or anything.
Thank you, Gurushantappa sir. That was an excellent ward rounds of pancreatitis, and I thank the panelists also, all the postgraduates. We have few questions in chat box, and most of the questions are from Ravi Shankar. So I request Ravi Shankar to put your comments or questions. Ravi Shankar sir, unmute yourself and you can talk.
I think they were all sequential as it was being done. I think the answers were already given as and when it went on. I think the only thing I would say is when there is acute pancreatic fluid collections especially in this case, see the endoscopic treatment would be more appropriate when there is a pseudocyst that is formed, because even to put the opposing stent, you need to have another cavity on the other side. But if there is no walled off thing, it will be difficult to do an endoscopic drainage. In those situations, laparoscopic drainage would be more appropriate. Once an organized pseudocyst is there, then I think endoscopic treatment will become more appropriate. Whatever this one Nagiriti stent, or what is it now called, the opposing stent, one in the pseudocyst and one inside the stomach. That would be more appropriate, and through that you can also suck out all the necrotic material also. But in an acute collection where there is a lot of fluid all around, where will the other side of the stent stay? I think it will be a difficult thing to do. So in that situation, laparoscopic drainage will be more appropriate, I think.
Rajesh sir, if you have some questions.
They have been answered, I think, throughout. I had
Yeah.
some basic questions as to why there is fever in pancreatitis and things like that. All was going on during the discussion.
Yes.
There is no question which has not been answered, I feel.
I think all questions are asked. We'd like to hear some final comments from Dr. Lakshman sir.
Very nicely done. Congratulations, Gurushantappa sir. I think it was very comprehensive, very simple, that all of us, postgraduates and the seniors, all of us together had a lot of learning in this session. Congratulations. I have only 3 observations or comments which may add to what you have already done comprehensively. One of them is that this enteral feeding must be beyond D3, D4. Even if the patient has no vomiting, it is not recommended that you do a nasogastric feeding tube. It has to be nasojejunal. That can be done either by blind method or, better still, endoscopically directed nasojejunal feeding. Fluid resuscitation was mentioned, but I think a central line is very central for treatment. I am sure it would have been done, but it was not stressed upon. And so I would urge all the postgraduates to learn putting a central line. That's the first one. Somehow surgeons have stopped doing it. We leave it to the anesthetists in the ICU department. But most of my trainees somehow have a go at, they always learn to do a central insertion, because you must do that as a very basic requirement for fluid resuscitation. Without a proper CVP, with third spacing of fluids, particularly in severe pancreatitis, you really cannot get an idea of how much fluids you have to give. Somebody put it in the chat box, what should it be? Should it be goal directed? Undoubtedly so, because that is the direction given by the sepsis, severe sepsis, the campaign that they have. And so it must be goal directed. Otherwise, I think very nicely done. My only other comment is, all these new things, as Gurushantappa sir and Ravi, all of them said, the minimally invasive things work very well. Endoscopic methods work if it's fluid. But many times, most of the time, it will be a big solid element, in which case it doesn't work well. And so what is minimum would become a laparoscopic necrosectomy, which is now gaining a lot of popularity. But if one doesn't have an experience in laparoscopic necrosectomy, do not hesitate to do an open necrosectomy. It is still a time-tested, good, safe procedure, which will save the life of a patient in infected pancreatic necrosis. Thank you very much, sir. Gurushantappa sir, very nice session. Thank you.
Thank you, sir. Yeah, definitely. Fluid resuscitation, I did not cover, because covering everything, I thought it becomes a lecture class.
Absolutely.
So that is, sir, in the open necrosectomy also, instead of having a laparotomy, there is an entity called a retroperitoneal open necrosectomy.
Yes.
Taking a posterior or posterolateral incision, going in the retroperitoneal area without opening the peritoneum. Correct. Like what we do for renal diseases or retroperitoneal surgeries. So you can enter into the pancreatic area on the left side in the posterolateral with a small incision of about 4 to 6 centimeters. Still, it is accepted and done often. This open, minimally invasive open retroperitoneal necrosectomy.
Correct. Yeah, I think Professor Neoptolemus in Liverpool, I think he wrote a lot of papers on what doing, as you said, using the laparoscope and doing a small incision and removing all the necrotic material under laparoscopic guidance. I think that has a lot of wisdom in that also.
Dr. Shivram sir, something. Rajesh is.
Rajesh
I
has
want
his
to
hand.
say.
One against that is it's a little unfamiliar anatomy. It's not like a laparotomy where everything is, so unless you're really familiar with that, it's a little difficult, I think, sir.
Dr. Shivram sir.
Normally, necrosectomy would be, it is not identifying what all, it is whatever is accessible, easily removable, the dead tissue, we are going to remove it.
I've seen a picture where they nearly took out the superior mesenteric artery also. That's why I'm saying that.
I think so. If no comments are there, we will.
Final comments from
It was
chairman.
an excellent program, sir. Thank you for conducting this program. The presenters, Kruti, Kim's Kruti, and Manipal Kruti, and Vijay really did an excellent job.
Thank
Thank
you.
you.
Hello.
Thank you, sir.
Can I make a comment from Imphal?
Yes, sir.
Dr. Jogendra sir, please talk.
Hello.
Yeah.
Yes,
Please,
sir.
please talk, sir. We are listening to you.
Yes. Yeah. Just one more technique that we have done here. I just wanted to mention. We have used ultrasound guided puncture and then used a regular PCNL technique to do this retroperitoneal necrosectomy using a nephroscope. So that is also possible under vision. So that is another technique I just wanted to mention for completion.
Thank you. Very nice, sir.
Joginder sir, good evening.
Good evening. Good evening.
Good evening, sir. Good evening, sir.
Nice to see you. Very
Yes,
nicely
sir. Yes, sir.
presented.
Yes,
We
sir.
are 8
Thank
of
you,
us
sir.
here, all postgraduate students. We are all listening to you very nicely.
Oh,
And
thank
we
you so
really
much, sir.
enjoyed it.
Thank you, sir.
Thank you.
Chandru, I think so. You can present the vote of thanks.
Yes, Ravishankar sir is.
Sir,
Ravishankar, final comment.
Chandru, one though.
Yes, sir.
After the necrosectomy, I think it is important to put either drains or sump drains into the pancreatic bed so that irrigation can be done, and that will help patient recover. I think certainly drainage after the necrosectomy is extremely important, whether it's done minimally invasive or open.
Yes, sir. If no more questions, we'll wind up. Behalf of KSCASI, I thank Dr. Gurushantappa Yalagachin, sir, for an excellent moderation of today's session, and also all the speakers, Dr. Kruti and Dr. Vijay, and all the members of KSCASI, executive committee members, both state and national, and all the postgraduates who have joined here. Thank you, everyone. Thank you, one and all. Good night,
Thank
everyone.
you.
Good
Thank
night,
you.
everyone.
Thank you. Good night.